Good morning, everybody. Welcome back. I'm so happy to meet you again in Point of Care in Clinic 17. Really, use of point of care ultrasound in clinic is great. It helped me a lot in management of my patient. You will see in this series of point of care ultrasound in clinics, in this patient, you will know how accurately and professionally, in professional way, when to use diuretics, when to escalate, when to stop diuretics in your patient with objective meaning, with visual management. I saw a 65-year-old female patient in my clinic recently. She is known case of long-standing diabetes mellitus, hyperlipidemia, hypertension. She is well controlled on oral hypoglycemic and statin. She is taking bisoprolol and furosemide for moderate degenerative aortic regurg and apixaban for AF. She came because of worsening dyspnea and lower limb edema. She is fully conscious, cooperative, obese with body weight 109 kilogram, body mass index 33. She has beating lower limb edema, heart rate 120 per minute AF, blood pressure 170/80, chest clear, heart AF. As you see, she has many comorbidity. She is now complaining of worsening dyspnea and lower limb edema. There is disturbance in fluid balance in this patient, and we need to know what's going on in clinic. I started advanced critical ultrasound to help in her management, of this patient. First, patient has beating lower limb edema. On furosemide, we need to look for intravascular hemodynamic. This beating edema is interstitial edema. This is fluid overload in the interstitium. What about intravascular hemodynamic, which is very important in this patient with moderate aortic regurg and hypertension? I need to assess the right and left atrial pressure to adjust the diuretics. Just look into the inferior vena cava for this patient. The maximum diameter 2.8 and non-collapsing, less than 50% collapsing. That means, according to the American Society of Echocardiography, patient has more than 2.1 centimeter in diameter, maximum diameter of inferior vena cava, and less than 50% collapsibility. That means right atrial pressure is at least 15 millimeter mercury for this patient. So, in this patient has interstitial edema and right side high right atrial pressure. What about left atrial pressures? It's very important. According to the American Society of Echocardiography and European Association of Cardiovascular Imaging, to assess the left atrial pressure and diastolic function in patient with AF, you need to assess several parameters here. First, mitral deceleration time. If it's less than or equal 160 milliseconds, that means there is increased left atrial pressure. You need to assess the E over E prime in patient with AF. It's more than or equal 11. That means going with increased left atrial pressure. You need to assess isovolemic relaxation time. If it's less than or equal 65 milliseconds, it's going with increased left atrial pressure. And the recent diastolic dysfunction guidelines, British diastolic dysfunction guidelines, published this year, 2024, it make things more organized. In the first step, you need to assess for your patient the septal E over E prime. If it's more 11, it's 1 point positive. You need to assess the mitral E velocity. If it's more than or equal 100 centimeter per second, another point. You need to assess E deceleration time. If it's less than or equal 160 less than or equal 160 millisecond, another point, and tricuspid regurg velocity, if it's more than 2.8 millimeter per second, it's another point. So, if 3 of these are positive, that means your patient has impaired left diastolic dysfunction with elevated feeling pressures, and the left atrial pressure would be high in these situations. If it's more than or equal 3 point negative, it's normal feeling pressure. If it's only 1 point positive, 1 point negative, and not all 3 parameters positive, you will go to this second step. Okay, back to our patient. If, as you see, when I put the pulsed wave Doppler here at the tip of mitral valve in my patient and assess the E wave, because no A wave because AF, I assess the E wave here. Most of the E wave are above 100, the average above 100, it's 1 point. The deceleration time average is less than 160 millisecond, another point. And when I did septal E prime here, most of the E over septal E prime above 11, another point. So I have deceleration times very rapid and less than 160 millisecond, 1 point. Most of the E wave velocity more than 100. Most of the E over E prime above 11. That means I have now 3 parameter positive according to the British guidelines. And also here, the tricuspid regurg velocity here is positive criteria because it is above 280 centimeter per second. That means my patient has 4 criteria positive. That means my patient has increased left atrial feeling pressure and also has increased right atrial pressures and interstitial edema or beating edema. Does the increased left atrial pressure cause pulmonary edema? In my patient, really, most of the lung examination was A lines. That means there is no pulmonary congestion. You need to differentiate between increased left atrial pressure and pulmonary edema. In chronic patient, in chronic increased left atrial pressure patient, he may tolerate the increase and will not causing pulmonary edema. So my patient at this point has lower limb subcutaneous interstitial edema with increased intravascular space. Intravascular space. We can step up diuretics because we have interstitial edema and increase right atrial pressure and increase left atrial pressure. So we can step up diuretics. We add a small dose thiazide and spironolactone to furosemide. And you see here how great point of care ultrasound in clinic can help you. Clinically, the patient has hypertension, 170 systolic, and beating lower limb edema. This clinically, and by point of care ultrasound in clinic, I know now there is increased right and left atrial pressure. That means I can very safely step up the diuretics. Second, patient has moderate degenerative aortic regurg and uncontrolled rapid AF, despite the maximum dose of bisoprolol 10 mg per day. So I need to assess the left and right atrial systolic function to guide me about the next drug for controlling AF. I need to assess the degree of aortic regurg for adding arteriolar vasodilation. Patient has hypertension and refer to surgery if severe grade. This is the parasternal short axis view. There is good at the level of the papillary muscle, good kissing heart here, good contraction, good thickening and shortening. This is the long axis parasternal view, good shortening and thickening and dilated left atrium because of AF. Okay, systolic function of the left side by visual assessment is good, and M mode also is good. And here the right side visually TAPS is good. The upward movement of the tricuspid annulus is good. Thickening will shortening of left ventricle is good. TAPC is normal. That means good systolic function of both right and left ventricle. We can add rate control calcium channel blocker safely. We add diltiazem started by low dose. This is the great value of point of care ultrasound in clinic. Here, I know systolic function of the right ventricle and left ventricle is great, so I can add diltiazem without fear of negative inotropic effect of the drug, and I can benefit from the vasodilator effect of the drug in controlling blood pressure in aortic regurgitation, and at the same time controlling the rate with the beta blocker. Starting by low dose, gradually increase. Fortunately, the regurg is only moderate with vena contracta 3.7 millimeter, and the regurg flow is not reaching to the apex. It's going with moderate regurg. There is also moderate mitral regurg, mild mitral regurg. So we step up diuresis, adding diltiazem for proper control of AF. 2 weeks later, patient lose 8 kilogram in 2 weeks. It's great, good. No lower limb edema, marked improvement of the dyspnea, blood pressure now 150/80, heart rate 100 per minute, regular. It's very strange. The patient has long-standing AF. Follow up by point of care ultrasound in clinic. Now inferior vena cava is collapsing now. It's collapsing, totally collapsing, totally collapsing. That means, according to the American Society of Echocardiography, right atrial pressure now is 3 millimeter mercury, narrow collapsing inferior vena cava. Still regurg, but the contraction is good by visual assessment. There is good thickening and shortening, and the good visual assessment of the TAPC here. By putting the pulsed wave Doppler here at the tip of mitral valve to assess the left atrial pressure, which is very important in patients with moderate aortic regurg, I find here a wave, a wave, a wave. That means there is organized now atrial contraction. There is atrial contractions here. Is it sinus race or organized flutter? Let us see. But there is a restrictive pattern here denoting increased left atrial pressure. This restrictive pattern, E over A more than 2 in patients with cardiac disease, it is going with the restrictive pattern, diastolic function grade 3 and increased left atrial pressure. Is it the case? The ECG revealed here flutter wave, but this is properly organized atrial contraction. There is organized atrial contraction, but controlled atrial flutter, well-controlled atrial flutter with organized atrial waves here. But please, in atrial arrhythmia, you couldn't rely on the A waves, because in this patient there is stunning of the left atrial. Because of this stunning of the left atrial, you cannot rely on the E over A ratio. You cannot use E over A ratio in assessment of the systolic function of the patient with atrial arrhythmia or reverted from the AF, because of the stunning atrium will make the contraction of the atrium very poor and will make the E over A ratio too high. So this is very important. In all guidelines, in American Society of Echocardiography and European Association of Cardiovascular Imaging 2016 guidelines, and in the recent British 2024 diastolic guidelines, diastolic function guidelines, all stress you cannot apply the E over A ratio, you cannot use E over A ratio in patient with atrial arrhythmia or reverted from atrial flutter because of stunning of the atrial muscles and very poor contractions, so you will expect to see very low EA wave and high E over A wave. But if you if you consider there is organized atrial contraction here and look for other parameter of the diastolic function, you will see here E over E prime over lateral wave here. It is less than 13, and E over E prime in septal here it's less than 15, and left atrial volume is high because of AF. You cannot rely on left atrial volume because of AF. And you see here no tricuspid regurg at all. That means definite left atrial pressure here is decreased. And if you consider that the average E over E prime is less than 14 and the no tricuspid regurg and the only dilated left atrium, the diastolic dysfunction in this patient will be grade 1. And according here to the American Society of Echocardiography and the European Association of Cardiovascular Imaging, here as you see average E over E prime is less than 14, tricuspid regurg, no tricuspid regurg, and the only left atrial volume is high. That means 2 criteria negative and 1 positive. It's going with 2 negative, 1 positive. It's going with normal left atrial pressure, grade 1 diastolic function. So as you see here, point of care ultrasound in clinic help us a lot in giving medication and in follow-up the patient. And we add ARBs to control blood pressure because it's 150 over 80 and for follow-up, and the patient really is happy about this control. And I will repeat again, point of care ultrasound in clinic is great and will help you a lot in management your patient in clinics. And see you in another project about point of care ultrasound in clinic. Bye bye.